You're listening to He Said, a Cardiology Board Review Series. No fluff, just facts.
This episode is about left and right bundle branch blocks and left and right ventricular hypertrophy. Let's start with right bundle branch block. In a normal heart, V1 and V2, the leads that overlie the right ventricle usually should show small r and deep negative S waves since it reflects the negative signal from the dominance of the left ventricle. In right bundle branch block, the left bundle goes ahead and fires while the right bundle fires later. So V1 and V2, the leads that overlie the right ventricle, will show a small r, big S, big R prime, where the second R wave is the delayed firing of the right ventricle. This causes the rabbit ears in V1 and V2. Meanwhile, V6, 1, and AVL, the lateral leads which overlie the left ventricle, will have a QRS, small q, big R, small s, where the S is deep and wide or slurred due to the negative signal generated from late right depolarization. The slurred S wave in V6, 1, and AVL, the lateral leads, correspond to the big R prime of V1 and V2. Realize that although you will see the slurred S wave in V6, V6 will still have an overall upright QRS because the RV muscle mass is not that great to cause a totally negative QRS in V6. The QRS will be widened beyond 120 milliseconds in right bundle branch block. The normal left to right direction of depolarization is preserved. The LV is activated normally, so the early part of the QRS complex is unchanged. The delayed RV activation produces a secondary R wave, big R prime, in the right precordial leads V1 to V3 and a slurred S wave in the lateral leads 1, AVL, and V5, V6. There will be ST depression and T wave inversion in V1 and V2, reflecting repolarization of the delayed right bundle there, whereas in left bundle branch block, this would occur at V5 and V6. An incomplete right bundle branch block is if you have RSR prime in V1 or V2 and slurred S wave in 1 or V6, but the QRS is not prolonged beyond 120 milliseconds. In other words, if QRS is more than 120 milliseconds, inclusive of 120, it's called complete right bundle branch block. If QRS is less than 120 milliseconds, it's incomplete right bundle branch block. If all the features of right bundle branch block are there except the rabbit ear RSR prime, it is a 1 ear down QR prime, so no first R, just a big Q, big R prime, then that may be an enteroseptal MI, either new or old. So you have to watch out for that. Overall, to recap, right bundle branch block is a wide QRS more than 120 milliseconds, a big RSR prime in V1, rabbit ear pattern, and wide negative S waves in 1, V5, and V6. Next, let's move on to left bundle branch block. Normally, the septum is activated from left to right, producing small Q waves in the lateral leads. In left bundle branch block, the direction of septal depolarization is reversed to right to left, so the QRS broadens beyond 3 little boxes, 120 milliseconds. The right to left depolarization produces tall R waves in the lateral leads, 1 AVL and V5, V6. But these are very close together, producing only a notch at the top rather than two separate R and R prime waves of right bundle branch block, because the contraction of the delayed LV firing happens shortly after the normal RV firing, whereas in right bundle branch block, the LV, which would have gone first anyway, fires, and there's a delay before RV firing. In the right precordial leads in V1 to V3, there will be deep S waves after a tiny R in a small R big S pattern. Even though the left bundle is delayed, it is still very dominant, so it will overwhelm the tiny R coming from the right bundle firing and cause the main pattern to be a deep S, reflecting the negative signal detected in V1 to V3 from the left bundle firing. Note that the small R big S in V1 to V3 needs to have a narrow tiny R. If the R was wide, that would suggest a previous posterior MI. There will be ST depression and T wave inversion in V5 and V6, reflecting repolarization of the delayed bundle there, whereas in right bundle branch block, this would occur at V1 and V6. The ST depression and T wave inversion accompanying the notch R in V1 and V6 are discordant. Similarly, in V1 and V2, the deep S waves are accompanied by ST elevation and peak T waves, which are discordant. The discordance is because in bundle branch block or PBC, you lose that and you only have cell to cell transmission. So the depolarization occurs from endocardium to epicardium, and then repolarization also occurs from endocardium to epicardium. If there was concordance between the QRS complex and the ST segment in T wave direction, that would suggest ischemia. In terms of etiologies, the most common cause of left bundle branch block is hypertension and CAD. Other causes are dilated cardiomyopathy, rheumatic heart disease, infiltrative heart disease, and idiopathic. If somebody already has a CRTD placed, but they come in with acute heart failure of volume overload and ECG shows a new left bundle branch block pattern, that suggests that there is RV only pacing. So you should interrogate the device for LV pacing and capture. Now let's talk about left hemiblocks. Blocks can occur in the anterior or posterior divisions or fascicles of the left bundle called hemiblocks. The left anterior fascicular block is a positive QRS complex in 1 and a negative QRS complex in AVF. Left posterior fascicular block is a negative QRS complex in 1 and a positive QRS complex in AVF. The left anterior fascicle supplies the anterior and lateral walls. The left posterior fascicle supplies the inferior and posterior walls. The left posterior fascicle is not as organized as the left anterior fascicle because the left posterior fascicle's fibers are not organized as discrete bundles. So the left posterior fascicle is more difficult to be blocked. Left posterior fascicular block is less common than left anterior fascicular block because the left posterior fascicle is more resistant to damage than the left anterior fascicle because the left anterior fascicle is much thinner than the left posterior fascicle. Both left anterior fascicular block and left posterior fascicular block have normal QRS duration, unlike the bundle branch blocks, which all have QRS exceeding 120 milliseconds or including 120 milliseconds. Let's look at left anterior fascicle hemiblock specifically. The left anterior fascicle is superior and lateral to the left posterior fascicle. So, if the left anterior fascicle is blocked and all the current goes to the left posterior fascicle, the polarization will occur from inferior to superior and from medial to lateral. Therefore, the axis of the polarization is moved upward and leftward, left axis deviation. This results in tall lateral R waves in 1 and AVL with tiny Q waves, so these are small Q big R complexes, and deep S waves in 2, 3, and AVFs with tiny R waves, so these are small R big S complexes. The R wave in AVL may meet the criteria for LV hypertrophy of being greater than 11 meters tall, but there will be no sign of strain pattern, so it's not technically LV hypertrophy. The R wave in AVL may have a prolonged time to peak, more than the one small box it usually takes. Left anterior fascicular block cannot be diagnosed until other causes of LAD have been ruled out. LAD meaning left axis deviation. Left axis deviation is actually one of the main ways of diagnosing left anterior fascicular block, to the point that if you see any EKG that has axis at negative 30 degrees to negative 90 degrees, which is in the northeast quadrant, you can bet that it'll be left anterior fascicular block. Just look for lead 2 being negative in addition to lead AVF being negative and lead 1 being positive. Now let's move on to left posterior fascicle hemiblock. The left posterior fascicle is inferior and medial to the left anterior fascicle. If the left posterior fascicle is blocked and all the current goes to the left anterior fascicle, the polarization will occur from superior to inferior and from lateral to medial. Therefore, the axis of depolarization is moved downward and rightward. That's right axis deviation. This results in tall R waves in 2, 3, and AVF and deep S waves in 1 and AVL, which is precisely the opposite of what we saw in left anterior fascicular block. The R wave in AVF may have prolonged time to peak more than the one small box it usually takes. Left posterior fascicle hemiblock is very rare in isolation. It usually occurs with right bundle branch block in the context of bifascicular block. Left posterior fascicle hemiblock cannot be diagnosed until other causes of right axis deviation has been ruled out, including TCA overdose, lateral MI, RV hypertrophy, chronic lung disease, and acute PE. You also have to exclude right atrial enlargement. Make sure there's no P pulmonale, which is the TP pattern P wave in lead 2 that is more than 2.5 millimeter tall, and the lead V1 up and down P wave should not have any up part that is greater in height than the up part of V6's P wave. Exclude RV hypertrophy by looking at V1 and making sure that the R to S ratio is not greater than 1. Exclude lateral MI by making sure that there are no Q waves in the lateral limb leads and the lateral precordial leads. Make sure that there is no S1Q3T3 that would suggest acute PE. This is important. Without excluding these things, you can't diagnose left posterior fascicular block, which is the diagnosis of exclusion. Again, right axis deviation is one of the main ways of diagnosing left posterior fascicle block, to the point that if you see any EKG that has axis positive 90 to positive 180, which is in the southwest quadrant, you can bet that it'll be left posterior fascicular block. Now we will talk about bifascicular block. What exactly is bifascicular block? It just refers to right bundle branch block plus one of the left fascicle hemiblocks. So the most common one is right bundle branch block plus left anterior fascicular block, and the other one is right bundle branch block plus left posterior fascicular block. Some people also call left bundle branch block a bifascicular block because they count the left anterior fascicle and the left posterior fascicle as two fascicles being blocked. Causes of bifascicular block include ischemic heart disease, which is the most common, hypertension, aortic stenosis, anterior MI, congenital heart disease, hyperkalemia, and primary degenerative disease of the conduction system. Bifascicular block has features of both right bundle branch block and left anterior fascicular block or left posterior fascicular block. You will have prolonged QRS more than 120 milliseconds and big RSR prime rabbit ears in V1 and V2, and corresponding slurred S waves in V6 and V1. V6 and lead 1 as a result of right bundle branch block. You will have a left axis deviation of negative 30 to negative 90 degrees of left if there's left anterior fascicle block, or right axis deviation of positive 90 to positive 180 degrees if there's left posterior fascicle block. If there's left anterior fascicular block, lead 1 or lead AVL will have a small Q big R, and lead 2, 3, and AVF will have a small R big S. Conversely, if you have left posterior fascicular block, lead 1 or lead AVL will have a small R big S, and lead 2, 3, and AVF will have a small Q big R. The combination of right bundle branch block plus left posterior fascicular block is more unstable than the combination of right bundle branch block plus left anterior fascicular block, because in right bundle branch block plus left posterior fascicular block, the remaining fascicle, the left anterior fascicle, is only a single fiber. Fortunately, bifascicular block has a low risk of converting to a complete heart block at 1% per year. If you have unexplained syncope in the setting of bifascicular block, implanting a pacemaker gets a 2A indication. If EP study shows a prolonged HV interval, normal is 35 to 55 milliseconds, you should place a pacemaker, class 1 indication, because of the bifascicular block. A permanent pacemaker is sufficient. If the patient is subsequently found to have frequent RV pacing, more than 40%, then an upgrade to CRT can be considered. We all know that chest pain in a person with new left bundle branch block is highly suggestive of ischemia. Also know that chest pain in a person with a new left anterior fascicular block is also ischemia. Can athletes with bundle branch blocks participate in competitive sports? According to the AHA-ACC 2015 scientific statement on eligibility and disqualification recommendations for competitive athletes with cardiovascular abnormalities, athletes with right bundle branch block who do not develop periods of type 2 second degree AV block or complete heart block spontaneously or during exercise and who have no symptoms or heart disease identified by appropriate testing that otherwise precludes participation can participate in competitive athletics. That's a class 1 recommendation. Athletes with permanent or rate dependent left bundle branch block who do not develop spontaneous type 2 secondary AV block, MOBITs, or complete heart block, and who have no symptoms or heart disease identified by appropriate testing that otherwise precludes participation, can participate in all competitive athletics. That's class 1. In athletes with left bundle branch block and concerning symptoms, an EP study is recommended. An athlete with a normal HV interval and a normal AV conduction response to pacing can participate in all competitive sports unless otherwise restricted by their structural heart disease, class 1. On EP study of athletes with left bundle branch block, those with abnormal AV conduction characterized by an HV interval exceeding 90 milliseconds and a His Purkinje block should have pacemaker implantation, class 1. So all of these that I just told you about are class 1 recommendations. So that's what we have for left and right bundle branch block and the hemi blocks. Now let's move on to left and right ventricular hypertrophy. Hypertrophy, which is thickening of the myocardium, involves the polarization of a greater number of muscle fibers, thus increasing the amplitude of the waveform on ECG. Normally, LV vectors dominate because the LV is thicker than the RV at baseline. LVH may cause a slight left axis deviation to negative 30 degrees, whereas RVH will cause a right axis deviation of up to positive 90 degrees. More importantly, it will cause the following changes to the R height, S depth, SC segment, and T wave. Let's delve into left ventricular hypertrophy first. What causes LVH? Things that increase pressure in the LV, such as systemic hypertension, aortic stenosis, aortic regurgitation, mitral regurgitation, MI, and hypertrophic cardiomyopathy. Where do we see tall R's and where do we see deep S's? In LVH, because the fibers of the LV are abnormally strong, you will have tall R waves in the lateral leads, 1, AVL, V5, and V6, and corresponding deep S waves in 3, V1, V2, and V3. The specific heights and depths are as follows. In the Sokolow-Lyon criteria, the R wave of V5 or V6 plus the deep S waves of V1 or V2 should exceed 35 millimeters. Or you can have the R of lead AVL exceed 11 meters. This has a sensitivity of 20% and specificity of 85%. How about the Cornell voltage criteria? There, the height of AVL, the R of AVL, plus the deep S wave of V3 should exceed 28 millimeters in men and 20 millimeters in women. The sensitivity is 42% and the specificity is 95%. How about the Cornell product criteria? There you have the R of the AVL plus the deep S waves of V3 times the QRS duration should exceed 2440 millivolts times milliseconds. That has a sensitivity of 51% and a specificity of 95%. So you can see that the specificity of all these criteria are very high, around the 90s, but the sensitivity is not that high and slowly increases as you move from the Sokolow-Lyon criteria, the Cornell voltage criteria, and the Cornell product criteria, which has the highest sensitivity of 51%. What about the ST segment and T wave? The lateral leads, 1, AVL, V5, and V6, are allowed and expected to have downsloping ST segment depression of 1 millimeter or more and T wave inversion. The anteroseptal leads, V1, V2, V3, are allowed and expected to have upsloping ST segment elevation of 1 millimeters or more. Notice that in all cases, the ST segment change should be the opposite direction of the QRS complex. Now let's move on to RVH, RV hypertrophy, the last section of this podcast. What causes RV hypertrophy? Things that increase the pressure in the RV, such as pulmonary hypertension from COPD, PE, mitral stenosis or mitral regurgitation, pulmonic valve stenosis, or congenital heart defects such as ASD or VSD. Where do we see tall R's and where do we see deep S's? Normally, the left ventricle is much thicker than the right ventricle, which is why the QRS complex is normally driven by LV vectors. So, for RV hypertrophy to show out on ECG, the RV hypertrophy usually must be quite severe. Since the RV vectors are predominant, you will have tall R waves in the inferior leads 2, 3 AVF and anteroseptal leads V1, V2, V3 that should be greater than the depth of the S wave. In V1, the R wave should be at least 7 millimeters tall. Meanwhile, you should see a deep S wave in the lateral leads 1 AVL, V5, V6, which should be deeper than the height of the R wave because on this left side, you are seeing the negative deflection resulting from the relatively stronger RV vectors. What about the ST segment and T waves? The inferior leads, 2, 3 AVF, and anteroseptal leads, V1, V2, V3, are allowed and expected to have downsloping ST segment depression of 1 millimeters or more and T wave inversion. V4 and V5 can also exhibit T wave inversion. That's all for left and right bundle branch blocks and left and right ventricular hypertrophy.
This podcast is intended for qualified healthcare professionals and is designed for training purposes only. These materials should not be used for direct patient care or as a substitute for independent clinical judgment. For more educational content or to submit suggestions, visit www.rehu.com/meded.